Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the Southwest Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a haemareg.
And let's get started on today's topic.
From basics
to brilliance. Hello, David. How are you?
Hi, Harry. Yeah, very good. Nice to see you again.
Yeah, you too. I thought we'd just jump straight in with a case today.
Okay.
Yeah?
Are you going to tell me what it's about, or have I got to try and work it out on my way through?
Well, actually, maybe it would be more fun. No, I should probably tell everyone for the listeners that driving what they're doing while listening.
Yeah, I'm interested, listeners. I do know what it is. I'm just being facetious.
So we're doing acquired haemophilia A today. Spoiler alert. So
it would be strange if for the second test I asked for, it's like, oh, can I have a Bethesda? You'd be like, oh, come on now.
So we're doing acquired haemophilia A today. There's quite a lot of overlap with that of haemophilia, but we'll sort of highlight the differences as well. So let's start with a case. I've got a 75-year-old male. This is a real case that I remember very well. 75-year-old male, had a few days history of left leg swelling, like swelling of the calf. Seen by the GP, who reasonably started the patient on a DOAC for a presumed DVT and booked a Doppler via, the DVT pathway. But then less than 24 hours later, came into A&E with a huge swollen leg and a big thigh haematoma, and had a CT scan which demonstrated a big bleed into the muscle of the leg.
Yeah.
What are you thinking?
So, what would I do? I'd like a set of bloods, and including a coagulation. Mm-hmm. I'd like to know what the APTT and the PT is, please.
Mm-hmm. Okay, so they were both prolonged because obviously the patients had a DOAC. So that prolonged them both slightly.
Good point. I guess from there, as long as they are sort of, there's no neurovascular impediment to the distal limb, I'd probably like to give it a washout time. Okay. Although I would be a little bit worried and be thinking about reversal things if he's on a DOAC.
Mm-hmm. Okay, yeah, great. So you want to establish, firstly, as you say, because you're thinking maybe reversal might be required, depending, and thinking compartment syndrome is really important. And we'll go into the ways in which acquired haemophilia A often presents, but compartment syndrome can be a way. So make sure you assess for that, and neurovascular, as you say. And then you want to know, like, when they last took the DOAC, what dose it was, kidney function, liver function, to kind of establish how long, as you say, it might take for the DOAC to wash out. And probably, David, in this situation, you're quite worried about a patient having an active bleed into their leg. Yeah. You're probably going to want to ask the lab to see if they've got DOAC stop or something like that they can use to get rid of the DOAC in the sample, so that you can then do your tests again on that.
Oh, so in the actual test?
Yeah, you can. Sometimes, labs can sometimes add something to get rid of the DOAC. It's a bit of a nasty case that I've given you, but it's just a real life case, and it shows that, like, sometimes, someone comes in and you might have your textbook answer about how you screen for acquired haemophilia A, but then actually real life gets in the way. Okay, good. So we add a DOAC stop, let's say. I can't remember what we actually did. And now we have an isolated prolonged APTT. What would you want to do next?
So I'd like to do a mixing study.
Mm-hmm. Okay, and it didn't correct on incubation.
Which is suspicious.
Mm-hmm.
And then I do a Bethesda study.
Okay. Yeah, so I'd probably start with assaying your factor VIII and your other factors within the intrinsic pathway first. So
I've spent too much time doing this haemophilia stuff. I'm going straight to the Bethesda. I've forgotten the basics.
So your factor VIII comes back as low, and it's non-parallel. And then you do a Bethesda assay.
Yeah.
So we do a Bethesda assay, and it comes back with 14 Bethesda units as the inhibitor.
Okay.
So we have a diagnosis of acquired haemophilia A.
I guess in this case, you would kind of look back at it was his, wasn't it, previous coagulation studies, and if there's
Yeah.
no issue previously, we'd be like, this clearly is acquired. This has come from somewhere.
Yeah, you're right, because I guess the differential could be that he's had a mild haemophilia A all of this time, and he's just never had any, bleeding challenge before, although it seems unlikely at the age of 75.
Yeah.
But that is
Yeah.
always a differential, and so I guess we didn't really talk about at the beginning that you should take a good bleeding history, and establish any other bleeding events in that person's life, in case actually they have von Willebrand's or something else, and then the DOACs just tip them over the edge.
Yeah.
Good. Okay, so that's our case. I think you did a pretty good job of that, David.
I'd have got there.
Yeah, exactly. So let's start by just having a chat then more generally about haemophilia A, acquired haemophilia A. Typically a disease of the elderly. So 85% of people are over the age of 65. And the mortality can vary anywhere between 8 and sort of 40%. So it can be quite a lethal condition. So presentation, this man obviously presented with a swollen leg from a bleed. Do you know what are the common bleeding presentations in acquired haemophilia A?
So I assume, as opposed to the joints that we see in our sort of genetic haemophilia, are they sort of soft tissue bleeds? So large hematomas, muscles, mucosal, that kind of thing.
Yeah, exactly. So a hemarthrosis, unlike in haemophilia A, like genetic haemophilia A, acquired haemophilia A is actually very uncommon to get a hemarthrosis. Instead, as you say, GI, urogenital bleeding are both common, as well as retroperitoneal bleeding and bleeding into muscles. And the retroperitoneal bleeding and bleeding into muscles both can lead to compartment syndrome, as we said earlier. Okay.
Nice. Yeah.
Are there any other things that would make you think in a bleeding history, someone presenting with bleeding, that would make you think about acquired haemophilia
A? Not specifically in this man, but pregnancy.
Okay. Why do you say pregnancy?
Because is it more likely to sort of produce autoantibodies because you've got a little parasite inside you creating all kinds of amok with your immune system?
Yeah, I mean, you're right, actually. It is more common in pregnancy. And the same with things like TTP as well, which is another acquired kind of clotting problem. So, yes, pregnancy. Anything else that would make you think about it being potentially acquired
malignancy?
haemophilia? Yes, very good. So about 15% of acquired haemophilia A is related to cancer. And often, if you don't diagnose the underlying cancer and treat that, it can be really, really difficult to get the patient into remission. Anything else?
Is this like one of those kind of predisposition things where if they have other autoimmune conditions, they're more likely to pick up this one?
Yeah, great, David. Exactly. So autoimmune disease is associated with 17% of acquired haemophilia A. So your presentation is really bleeding of less classical places than in actual haemophilia A. So no joint bleeding, for example. And it's an unexplained new bleeding in which the patient hasn't previously had a bleeding history. Good.
Yeah, nice.
Okay, so how do we make a diagnosis of acquired haemophilia
A?
What's the pathogenesis behind it, actually, first?
So the pathogenesis.
Yeah, like what's actually causing?
So it's an autoantibody against factor VIII.
Very good. And so how is that different to an inhibitor that you can acquire in genetic haemophilia A, for example?
So that's an alloantibody, isn't it? It's against other people's factor.
Yeah, exactly.
Yeah, because you don't have any factor, so you're seeing it as foreign.
Yeah.
So yes.
Exactly, David. So an alloantibody is where you're making an antibody against extrinsic factor VIII as an autoantibody, which obviously can cross-react with your own factor VIII. For example, if you're a mild haemophilia A and you develop an inhibitor, you can develop a severe phenotype from the alloantibody. But
Yeah.
in acquired haemophilia A, you're somebody that has normal factor VIII levels, and then you randomly make an autoantibody against your factor VIII, which neutralizes its ability to work, so that you then get this bleeding phenotype. Good. And I think the reason why I just bring that up first is that it's really important to acknowledge that the autoantibody and the alloantibody against factor VIII behave in quite different ways, and they have quite different properties.
Ah.
So, where we talk about Bethesdas and their really
Mm.
useful assay for telling us, well, what does a Bethesda tell us in terms of an inhibitor in normal haemophilia A? What's it a
The
measure of?
strength of the inhibitor?
Exactly, David. It's the strength of the
Yeah.
inhibitor because it's how much inhibitor is needed to neutralize like 50% of factor VIII. And so that tells us, therefore, how likely that patient is to bleed, how much of a problem that inhibitor is, and it tells us about the phenotype of what we're expecting to see in terms of bleeding. But really unusually, in acquired haemophilia A, the Bethesda units that you get for your inhibitor, for your autoantibody, do not correlate with the bleeding phenotype. So you can have
Oh.
a Bethesda of like 200, or you could have a Bethesda of like 2, and they may have completely different bleeding phenotypes in the opposite way. The person with the really high Bethesda unit assay may have very little bleeding compared to somebody with a Bethesda unit of 2, for example. Like it just doesn't correlate in the same reliable way as it does with normal haemophilia A. The
That's
reason
starkly unhelpful.
I know, exactly. It is unhelpful, but it's worth mentioning because otherwise you might add some gravitas or weight to that result because you're used to dealing with inhibitors in normal genetic haemophilia A. So the reason for that is that they follow different order kinetics. So an alloantibody is a type 1 first order kinetics. So you've got your factor VIII with a straight line against incubation time. So the more time that the antibody spends with the factor VIII, the more it will be inhibited in a straight line. But with your autoantibody, it follows second order kinetics, so it's not a straight line. And that's essentially why you can't use the Bethesda assay to predict what the phenotype's going to be of that patient with acquired haemophilia A. Does that make sense?
How interesting. Yeah, no.
Yeah.
Yeah.
Great. So, and we've talked about the possible triggers of this autoantibody in terms of what we're looking for in the history. So we've taken a history, we've done a bleeding history, we've established the patient's got bleeding. And then what other tests in the lab are you going to ask for?
I'm not sure.
So initially you're going to do your APTT and your PT,
Yeah, yeah.
and
Yeah.
that's going to be an isolated prolonged APTT. Then you're going to do a mixing study. Any details about the mixing study that you'd want to kind of emphasize? Empathize?
Nice.
Would you like to empathize
Yeah,
with the
I would
mixing
love to
study?
I'm going to
I
empathize
can't
with
talk today.
I'm going to empathize with the mixing study and
Oh
make sure
God,
they have
sorry. It's been a long day.
the decent amount of incubation time
Yeah,
we
okay.
mentioned before. So one
Very good.
at type T equals 0 and then one at 2 hours.
Yeah.
And then I think we've previously talked about different types of mixing studies. How much
Okay.
does the patient? How much is the control? I
Yeah, very
can't
good.
remember what the actual numbers are though.
So we normally do a 50-50 mix. That's kind of a standard thing. 50 parts patient's plasma containing potentially the inhibitor and 50 parts normal plasma containing the factor VIII to be neutralized. But sometimes that can lead to flooding of a weaker inhibitor. So what you can do is do an 80-20 mix. So it's 80 parts of the patient's plasma and only 20 parts of the normal plasma. And that can, by using less of the normal plasma and more of the patient's plasma, it can prevent you from flooding a weak inhibitor with too much factor VIII. So that can be more
Great.
sensitive to look for
Yeah.
an inhibitor if that's what you
Yeah,
are
yeah.
expecting.
Lovely. Yeah, less false negatives. You don't reassure yourself.
Exactly. Yes. But essentially, I think the message in the latest guidelines is don't waste loads of time doing lots of mixing studies because ultimately it's not going to give you a diagnosis. It gives you a clue as to where you're going, and with the
Yeah.
history in particular, with it being an acquired bleeding history that's recently occurred, you're going to be more suspicious for some sort of acquired problem. And so as a result, don't waste loads of time doing lots of mixing studies. They said just move straight on to, your relevant factor assays. So you're going to do your factor assays, and if you've got a prolonged isolated APTT, in my experience, you should just do all of the factors for that intrinsic pathway.
Yeah.
Don't just request the factor eight because that's most likely. Because if the factor eight comes back as fine, then you've
Yeah.
got to go back to the lab and beg them to restart the big machine and, then run all your other factors. So I usually bring some vegan iced spiced buns for the guy at our lab that does all of our factor assays and beg him nicely to do all of the intrinsic pathway factors. And so do 12, 11, 9, 8 and see what you get. And what are you looking for? What should the machine flag to you if there is an inhibitor when you do your factor assay?
So there should be a low amount of factor eight in this occasion.
Yes. So you would get a lower result because on your factor eight assay, because there's an antibody, an inhibitor that's preventing factor eight from working properly, both in the body and in our lab tests. But what else should the machine flag to you when you do those factor assays in somebody with acquired haemophilia A?
This is that thing where they're non-parallel, but I don't.
Yes.
I'll have to go back through some of our episodes to work out what that actually means.
Yeah, it's just basically you'll remember, or you may remember by listening back to one of the other podcasts, and same for people at home. But you basically always do at least 3 dilutions of your patient's plasma when you're assaying the factor level, so that you can basically draw a line through those 3 plots, and then you can compare that to your control plasma. And you need to make sure that they're parallel, so less than 20% deviation between those 2 lines. And if the lines do deviate, then either you've plotted your graph wrong, or more likely you've got something that's interfering, and therefore the interfering antibody is being diluted out at a different rate to that of your factor, basically. So that's when the line becomes
that makes
bendy.
sense.
Yeah. So the we don't actually do that manually in the lab. The machine does that all for you, but it will flag then when something is not, when there's non-parallelism, which essentially means your factor 8 level is probably not very reliable. But more importantly, it tells you that there is something inhibiting. So that's what you would then get. So whenever you get non-parallelism, one of the things that you need to check for is lupus anticoagulant, okay? Because that can cause a prolonged APTT but not be clinically relevant, but messes with all of our lab tests. Obviously, you also want to check that there's no anticoagulant in the patient's blood, and like with the DOAC, for example.
Yeah, with our case study.
Exactly. And then basically, once you find that there's a low factor level and it's non-parallel, then that's when you would go on to do a Bethesda assay. So that's, if you remember, essentially a glorified mixing study of your patient's plasma containing your antibody and your reference plasma, and you incubate them together for 120 minutes, and then you assay the amount of factor that's left, and then you see how much that drops by, and that basically gives you a measure of the strength of your inhibitor, which in this situation of acquired haemophilia A isn't that useful for predicting clinical phenotype, but it's still useful for confirming that there is definitely an inhibitor. So that's why we do it. And just a side note, I noticed in one of those UK HDCO teaching episodes that are available on the Path portal that are really good, they said that in Oxford, they upfront do both a human Bethesda, which is the Bethesda we've just been talking about, but they also do a porcine Bethesda, where instead of using reference factor 8, normal factor 8, they use porcine factor 8 up front.
Interesting.
Why do you think they might want to do that, David?
Because it shouldn't be affected by the auto antibodies. They should be they're too different?
Well, it's more about knowing whether that patient's inhibitor can cross-bind to porcine factor 8.
Yeah.
Or whether it can only bind to human factor 8, because like when we talked about inhibitors in genetic haemophilia A, I keep calling it genetic haemophilia A just to clarify. Sorry.
It's like non-acquired.
I know, yeah, non-acquired haemophilia A. In that one, we want to know whether we can use the product Obizor, which is our porcine factor 8, which is a very useful drug in haemophilia patients with an inhibitor. And so I just thought it was really interesting that in Oxford they use that they do that assay up front. So they'll run a human Bethesda assay and they'll run a porcine Bethesda assay with porcine factor 8 at the beginning, so that then as soon as they've diagnosed the patient, they know what's available to them to treat the patient. Which is quite snazzy.
Sensible.
Yeah.
Is there any role for like an ELISA here?
It's a good question. Probably not. And the reason for that, well, usually no, because presumably most of the time your autoantibody is going to bind to your factor VIII and neutralize its ability to work, and therefore your functional lab assays are going to pick up that inhibitor.
Yeah.
I guess the caveat to that is when I saw somebody with an antibody that bound to the factor VIII and caused increased clearance of it. That's really, really rare, but I guess that wouldn't affect your lab assays, so you might miss an inhibitor in that situation. So yeah, good question, but most of the time, no.
Okay, yeah. So yes,
So
but
yes,
practically
but
no.
practically no.
Yeah.
Exactly.
Got it.
Yeah. And so that's basically how you'd work it up. So then you get your Bethesda and you've got an inhibitor confirmed. So you're like, okay, cool. And then other investigations you then need to go on to think about. Obviously, full blood count, biochemistry, calcium and LDH to think about cancer-related things in the background. Any other things you might want to test them for? Or other tests you might want to send?
No, from a lab point of view, I'm not. No, I can't think.
No, that's fine. Viral serology, because we're going to give potentially things that can carry viral infections. So, I mean, they shouldn't, but there's always a risk. So it's good practice to do Hep B, Hep C, HIV, and hepatitis A virus. Also, I think because some of those viruses can sometimes trigger the autoantibody. And then on that same kind of path of thinking, it's about thinking about secondary triggers of the acquired haemophilia A. So doing a chest x-ray, thinking about doing a PSA in men, thinking about doing a breast exam in women, and then considering things like an autoimmune screen, a myeloma screen, a CT, CAP, and a bone marrow biopsy, depending on what you're thinking in terms of looking for underlying secondary malignancies or autoimmune.
Okay. Yeah, that escalated quite quickly.
Yeah. Any questions about anything so far about how to diagnose acquired haemophilia A?
No, I think that's pretty covered it.
Okay, cool. And just to say, acquired haemophilia B also does exist, as does acquired von Willebrand disease, but they're both less likely or they're rarer, particularly when you've got an isolated prolonged APTT. Okay, so treatment then. So what do you think are going to be some of the key treatment points that we need to make sure we think about in an acquired haemophilia A?
You've caught me a bit. I was going to say, I had in my head and ready to go. I was going to say bypassing agents. That's what I was going to say.
Very good. Then,
okay.
Would you give bypassing agents in everybody though?
Well, this sounds far too loaded. I guess depending, if I can eradicate the autoantibody, I think that's probably, to my mind, a preferable thing to do. Absolutely. So I guess if they're having a big bleed, I'm like, probably steroids are going to take a little while to get going. So I'd want to give bypassing agents to people who I'm worried about, who have serious complications, including compartment syndrome.
Absolutely. So if someone is bleeding with acquired haemophilia A, which most of the time they'll have at least had some sort of bleeding history, or how on earth did you get to the diagnosis? But if they haven't got active ongoing bleeding, you might not need to give bypassing agents. Remember your general measures, so local measures, applying adequate pressure to the area of bleeding. Or
this is your rice again, is it?
I know, I can't talk today, I don't know. Oh, you mean
rest, ice, compress, elevate.
I thought you were just taking the mick out of the fact that I can't. Completely fair enough.
I can words today.
Bit of a problem when you're doing a podcast, isn't it? But yeah, local measures.
I was just going to say, you look wonderful on the camera, if that's helpful, podcast members.
Oh, I look knackered. And then you've got tranexamic acid. Don't forget tranexamic acid, but don't use it in combination with what?
Fever?
Yes. And then you've got your bypassing.
See my brain going to free fall there.
And then you've got your bypassing agents. So you've got Nova-7, Feber, Obazor, and emicizumab. Emicizumab is not currently licensed in the UK for acquired haemophilia A. We'll come back to that. So those are your if bleeding measures. Also, a big thing is avoiding iatrogenic bleeding, because in hospital, we're constantly doing invasive things. So making sure that everyone understands that is really important. So minimal blood pressure measurements. And if you do, take them manually so that you're not having to squeeze the arm too much, because they'll just develop hematomas. It's horrible.
Yeah.
Limit venesection. So don't place a cannula unless you need to. and limit the number of blood tests that you take. Falls prevention is a big one. Don't let them fall and hit their head whilst they're an inpatient. That is bad. And make sure that you've reviewed their drugs. Stop any antiplatelets, stop any anticoagulants like the DOAC in our case, and avoid any non-urgent surgery or invasive procedures that don't need to happen, okay? Likewise, if the patient is pregnant, be aware that the inhibitor can cross the placenta. So you need to make sure you've got a birth plan, both for the mother and her bleeding risk, as well as the baby. So offering a C-section, no forceps, no Von 2s, cord blood sampling on delivery to check whether the baby has got an element of acquired haemophilia A from the maternal antibody crossing over. That's really important. And then the other thing to say is the other big headline is, as you said, about eradicating the inhibitor. And what do you think roughly that's going to involve?
Hopefully steroids.
Steroids. Of course it's steroids. Steroids.
I've just done a renal placement, and if the answer wasn't steroids, then
yeah, so it's steroids and then and sometimes with cyclophosphamide, and we'll come back to that in a minute. So basically, avoid iatrogenic bleeding. If they're pregnant, think about the birth plan for the mother and the baby. If they're bleeding, think about general measures, tranexamic acid, and bypassing agents. And then also, for all of them, you need to think about, okay, how are we going to get rid of the inhibitor? We're going to get rid of the inhibitor through immunosuppression. And don't forget MDT, 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 and you must involve your comprehensive care center. I remember with this case, with the man with the leg, we phoned Bristol straight away and got advice. And they were really, really helpful and really keen to give advice. So I found that a really positive experience.
Very wholesome.
Yeah, no, it was good. So, because sometimes it can feel a bit scary, like phoning a big centre and being like, oh, they're going to think we're really stupid or whatever. But actually,
I feel stupid most times I pick up the phone, so I'll be fine. They'll be like, oh, it's this guy again.
But you know what I mean? And actually, they were really keen, really helpful, and really supportive. So that was really
I guess in many ways, acquired haemophilia A is quite rare. So
actually,
when someone rings them up for it, they're probably like, good. Yeah. Something to chat about.
Exactly.
My fellow heme nerds down in the Southwest.
Exactly. So let's talk about bypassing agents specifically in acquired haemophilia A then, because we've talked about them in genetic haemophilia A, but not acquired haemophilia A before. So the research is less good because it's a rarer condition. Yeah. But the best study was this study called the EACH2 study, which was in 2012 and was basically the largest case series on acquired haemophilia A. And they basically showed no difference in bleeding or in thrombosis rates between FEBA and recombinant Nova-7, basically, factor 7, activated factor 7. So you might remember our discussion about Nova-7 versus FEBA last time, but what are the main headlines, David? What is Nova-7? Do you remember what the active kind of ingredient is?
So that's Nova-7's activated factor 7, isn't it?
Yeah, and it's recombinant, so no infection risk. There's no viral infection risk. Good. Yeah. But what was the real pain in the bum about Nova-7?
Oh, you're gonna have to remind me.
It was the half-life was only 2 hours.
Yes.
So you're continuously bolusing. It's really annoying. So every 2 hours you've got to give an infusion. FEBA, on the other hand, is what?
It's like APCC.
Yeah, activated prothrombin complex.
Prothrombin complex, yeah.
2, 7, 9, and 10, and the 7 is activated. So it's like the more activated version of the warfarin reversal, basically, is how I think of it. It's not recombinant, it's plasma-derived, so there's an infection risk with that, potentially. But it's got a longer half-life, which is much better at 6 to 12 hours. Both Nova-7 and FEBA are just dosed as a fixed dose per kilogram. And it's just a one-off dose. Well, it's not a one-off dose, but it's not like you can't titrate it to anything because there's nothing to measure. So you can overshoot and you can undershoot. You just kind of give it and hope for the best. As in contrast, the big advantage of Obazor, which is what's Obazor?
It's the porcine recombinant factor 8.
Yeah, very good. The beauty of that is that you can titrate Obazor and then measure. You can give a dose and then you can measure the factor 8 levels pre and 15 minutes post, and you can then kind of basically dose it after that based on what the levels of the patient are. So you start off with a sort of 50 to 100 like international units per kilogram kind of dose, and then you measure the levels afterwards, and then you go from there. So that can be really advantageous for patients where either they need surgery that cannot wait, or they're pregnant, so they need to deliver a baby that cannot wait. And you want that reassurance of knowing that the factor VIII levels are above 100 in case they need, spinal anesthesia or spinal analgesia, as we learned about last week. There is a difference. And or if they had significant cardiovascular disease where you just really don't want to risk overshooting and causing a thrombosis. So that's where Obizur is really useful. I think the reality of Obizur in a lot of hospitals, though, is in some hospitals you can't get factor VIII levels, particularly out of hours. There may not be anybody in the lab to measure it, and you might not be able to do a porcine a Bethesda assay at all. You just might not have the kit to do that in your lab. So, because ideally you'd check to see whether the inhibitor can cross-react with the porcine factor VIII. And if it can, there's no point giving Obizur. But in reality, what people tend to do is give a dose and then measure the factor VIII levels 15 minutes after. And if they're measurable, then you're probably all right. And if they're not measurable, then you're probably not, and you shouldn't give any more Obizur. But even that requires a lab that's able to turn around factor VIII levels quite quickly, which isn't always the case in a lot. So that's just to be aware of, as the advantage of Nova 7 and FIBA is that you don't need a lab geared up to be able to do those measurements. And then emicizumab would be a very attractive option in acquired haemophilia A, but sadly it's not licensed in the UK yet. There have been 2 big trials. There was a Japanese study in which they used emicizumab at presentation with immunosuppression until the factor VIII levels were above 50. And then there was also a German-Austrian study which instead used emicizumab at presentation, but with a deferral of immunosuppression to try and basically see whether they could kind of delay or reduce the amount of immunosuppression required, I guess. Both showed that it is effective, but it's just not been licensed in the UK yet. And I guess some of the unresolved questions are, what factor level cutoff would we use to say, okay, you don't need any more emicizumab? And like, should it just be reserved because it's probably a lot more expensive, I imagine, as a specific antibody? Should it be just reserved for those where FIBA's not working or Nova 7's not working, or should we be allowed to use it in everybody? So that's probably a watch this space kind of area of this condition, and probably will change in time.
I guess with the sample size being quite so miserable or good, depending on how you look at it, it's you're going to struggle to get dose dependent results.
Exactly. And so then let's talk about eradicating the inhibitor. So mean time to remission from the inhibitors 5 weeks. So that's a month. That's over a month. That's quite a long time for having what can potentially be quite a severe bleeding phenotype.
Yeah.
Good prognostic markers of going into remission are if you have a factor VIII level of 1 or more at presentation, i.e. if you can measure the factor VIII at all at presentation, that's a good sign. And the second one is if you have an inhibitor titer of less than 20. Now, I know I said that the Bethesda assay don't mean anything clinically in terms of bleeding phenotype, but they are a prognostic. But they are a prognostic sign. Okay, David. So
I feel like this is one of these essay questions that you get enough RCP and you feel smug as anything when you've written it. However,
but the reason why I bring this up is because in the H2 trial, they did kind of split the people up into those that they kind of thought would respond well and go into remission well, and those they thought would respond less well. So they divide them into favourable and unfavourable. So favourable were those with a factor VIII level of above or equal to 1 and a Bethesda titer of less than or equal to 20. And unfavourable is where the factor VIII level was less than 1 and the Bethesda was greater than 20. For the favourable patients, they used just steroids alone for 3 to 4 weeks. As for the unfavourable patients, they suggest that you should use steroids and cyclophosphamide up front together.
Okay.
And then if they don't respond, then for both of them, the second line is adding rituximab. So rituximab is quite slow. Yeah, it's a slow regime. It takes twice as long to respond, but that's what you can add in second line. And I think rituximab is only licensed for second line treatment in the UK. So you have to start with steroids plus or minus cyclophosphamide, depending on whether they're favourable or unfavourable risk. So steroids is a big whacking dose, so 1 milligram per kilogram, the kind of standard haematology dose. And then cyclophosphamide is 1 to 2 milligrams per kilogram a day. So the area that people
Sorry, and that's of prednisolone, yeah.
So prednisolone was 1 milligram per kilogram
Okay,
of
fine.
oral prednisolone.
Yeah, that's
Cyclophosphamide,
quite good going. Yeah.
yeah, and then cyclophosphamide, which you add for the unfavorable ones, like up front, is 1 to 2 milligrams per kilogram a day. For the favorable ones, if steroids alone haven't worked after a month, then you add in cyclophosphamide or rituximab, depending on which one you prefer.
Yeah.
And so that's generally the reason why we're trying to split them into favorable and unfavorable, is ultimately we're trying to reduce the amount of immunosuppression that these patients get. Because what do you think is the biggest cause of death in acquired haemophilia A?
Well, I'm assuming it's not bleeding.
Yeah, I'm annoyed that you know that. Damn it.
Well, you posed it at me.
Well, like, because you'd think it's bleeding, right? You'd think, oh,
Yeah,
well, that's
yeah.
obviously the immediate threat to life, but it's not. They die of infection, and
Oh,
that's because
wow.
of what we do to them.
Yeah.
You just think about that for a minute. That's actually the thing you should be worried about when your inhibitors going down and you're sending them home on their immunosuppression. You should be worried about sepsis
Yeah.
patient.
I suppose if you're on a whacking dose of steroids and the population tend to be not the
Older.
fittest,
Yeah.
yeah.
Yeah,
That's
exactly.
a risky run, isn't it?
Yeah, and I one of our few patients that I have seen with acquired haemophilia A did sadly die of infection, and it was really gutting because their inhibitor was in remission, and their
Yeah.
clotting was normal, but they still died. So we fixed them, but we didn't. So yeah, it's just it's worth remembering that, really emphasizing that actually.
Hmm.
And thinking about prophylaxis and thinking about other things with high dose steroids, so bone protection, gastric protection, all that kind of stuff. And remembering also things like VT prophylaxis once their factor VIII levels are recordable. If they're still an inpatient, think about their risk of a VTE. Good. Okay, and then follow up. So follow up's weekly factor VIII levels and inhibitor monitoring until they're in remission. And then after that, it's monthly of the factor VIII and the inhibitor screen for 6 months, and then it's 2 to 3 monthly for a year. So it's still quite a lot of follow up. There's a decent risk of relapse, and if they ever have any sort of future planned procedure, you should always do a factor VIII level in patients with a history of acquired haemophilia A, just to make sure that they haven't relapsed just before their big bleeding procedure. You know what I mean?
Yeah, and is that just the follow-ups that it seems a lot. Is that for everyone who presents with acquired haemophilia, or is that just the people that have got a, I don't know, slightly more unfavorable presentation, or is it just everybody?
I mean, that is the blanket advice, like guideline wise. But I'm sure, you'd tailor it to how fit the patient is, how much they want to come up to hospital, and all that kind of thing.
Yeah, I wonder, even if you found an incidental finding of a prolonged APTT, are you still going to put them through this kind of thing?
Yeah, I mean, it's unlikely. I think it's pretty unlikely to find somebody with just a prolonged APTT if they do have acquired haemophilia
Okay.
A. Based on my experience of n equals 3, and the fact that a prolonged APTT in someone who's not bleeding is more likely to be a lupus, to be completely honest, rather than something more clinically significant like an acquired haemophilia A. But yeah, it's a good question. I guess maybe we don't pick up those ones so much because we're not looking for it as much. Yeah. Any other questions, David?
No, I think that's pretty cohesive. Nice,
Yeah.
short and sharp episode.
Yeah. Well, it's quite a self-contained topic actually, acquired haemophilia A. So, shall we sum up with the golden nuggets?
Yes, please.
Okay, so where shall we start? I guess the first one is think of acquired haemophilia A in somebody who has an inhibitor with a bleeding phenotype who's old and might have underlying cancer. I guess that's fair to say.
Yeah.
Particularly if they've got bleeding that's not classical for genetic haemophilia A and they don't have the normal bleeding history.
I guess that whole presentation starkly is different to our genetic haemophilia A.
Yeah, exactly.
Young person with a joint, very young. Yeah.
Yeah, yeah. Secondly, I would say just think about the things that we can do to them that can make things worse. So iatrogenic bleeding really needs to be avoided. Don't take them to theatre. Don't do biopsies on them. Don't take unnecessary blood tests. Even blood pressure cuffs, do that manually as not to cause more hematomas. And then the third golden nugget should probably be, remember that there's kind of two main aspects to treating somebody with acquired haemophilia A. One, if they're bleeding, think about using bypassing agents along with general measures like applying pressure and tranexamic acid. But two is, don't forget that the main priority is actually getting rid of the inhibitor, and that's only going to come through immunosuppression. So it's going to be big dose of steroids, 1 milligram per kilogram, plus or minus cyclophosphamide as your first line treatment as per the each 2 study. And then second line is adding in rituximab usually. But remember that you're putting your patients at a big risk of infection. So bear that in mind whenever you're treating anybody with acquired haemophilia A.
And if in doubt, phone a friend.
Yes, always just phone the CCC. Yeah, they're there to help. Or if you work in the
CCC, that sounds, they've done well with that
acronym. Great. Okay, well, this was fun, as always.
Yeah, no, thank you, Harry. Very informative as ever.
Enjoying listening to it at home, listening to Dave and I prattle on about haematology every week.
Trying to introduce as many zoo animals as we can to the lab.
Don't think we got many in today. A pig, that was about it.
Just the pig.
Yeah.
Big shout out to the tortoiseshell cats, though.
So next week, I think we're going to finish our chats on haemophilia. So we've just got a bit on haemophilia B and like novel developments in haemophilia. So things like chemotherapy.
Nice, bit of CRISPR.
Yeah, a little bit of stuff to just put at the end of an essay, and also just for general interest.
When you're writing them in bullet points with 20 seconds to go.
Exactly, just chuck in a bit of trivia at the end. And then we'll move on to probably von Willebrand's as our next big topic to continue to get through that FRC path syllabus. So until next time, David.
It's been a pleasure.
See you later.
Bye.
Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time!